So at this moment, I'd like to take my turn, I guess, to make my presentation. I'm Jason Mitchell. I work for the Oceania Society for Sexual Health and HIV Medicine, which is the only professional society that works in the 21 Pacific Island countries and territories around the areas of HIV and sexual health. And I have the difficult task this morning to talk to you about how we responded to the HIV epidemic in the 21 countries and territories of the Pacific through the use of regional strategies to support national strategy plans in the various countries. So just an overview, we'll be giving you a little bit brief introduction to the Pacific, looking at a historical overview of our response in the Pacific, looking at the HIV epidemic status 4 decades on, some of the lessons learned and the change, and the introduction to the shared agenda. So I always like to start off by showing people a map of where the Pacific is situated in the world. And as you can see here, the Pacific Ocean, all 21 countries that I'll be talking about a span between, North, South America, right across through to Europe and Asia. So it's a very, very wide region. And this map just shows you the countries in which most of us have to work in, the regional organizations. So there are 22 countries and territories that are part of the Pacific, but I'll only be speaking about the 21 countries and territories of the Pacific, and these are the smaller countries and territories of the Pacific. I'm excluding PNG in anything I say in this presentation from here on end. And just to give you an idea of the size of what we're talking about, the population will range from a country such as Pitcairn Island of 67 people to the largest populated country in the Pacific of 850,000 people in Fiji. So those are really small numbers. But I suppose what's unique about the Pacific, just like most other parts of Asia, is the religious and cultural diversity, which adds to the challenges in working in this region. Because remember, we're coming from a regional perspective. Most of us working out of Fiji, which is in the center of the Pacific. The Pacific also has a third of all the world's languages. So of course, English and French, which is the other colonial language, is not the first language of most people of the Pacific. We have to work with or against sometimes 21 systems and governments of the 21 countries in the Pacific. And most of the support to the countries, as I said, comes from the regional level. So that's from one country we have to fly out, or we work from our offices wherever we are based in the Pacific. So just to go through a historical perspective of how HIV has impacted the Pacific and how we responded to that. So it's a little bit different, and we're not going to start with epidemic statistics and things like that. We'll just talk about how we responded as we went along. So in the first decade, from 1980 to 1989, HIV was considered someone else's problem, a non-issue for the Pacific and Pacific Islanders. The focus was mostly, in terms of response, was all about awareness, talking about just HIV's general information to the public. Most of the response was driven by governments, and as I said, was mostly just information sharing. The first case of HIV was diagnosed in 1984, and as this graph and as this map shows, by 1985 we quickly started to pick up cases in other Pacific Island countries. By the second decade, our country leaders were starting to get worried. There was a potential threat of HIV in entering and exploding within Pacific Island countries and territories. And unfortunately, we had to use the example of our closest neighbor, PNG, and we were saying, look at what's happening with PNG, it could happen to us. So there was a lot of our leaders were convinced to respond to HIV by creating some sort of fear amongst them of what could impact the smaller Pacific Island countries because of our very small populations. At this time, we started to engage with our national leaders, as well as our traditional and religious leaders. And I think our response so far, I think the success of it all has been because we started out with our leaders and then started to get support from the grassroots up as well. By the third decade, in 2002, the governments of the Pacific officially identified HIV as an important development issue and that needed immediate attention. By 2004, we had the first Pacific Regional Strategy on HIV and AIDS. There were other strategies before this, but it's a little bit confusing, and so I thought I'd just start off with what we know was on paper. And that's in 2004 strategy. In 2008, we had our second strategy, which was referred to as the Pacific Regional Strategy against STIs and HIV. So just a little, just a summary of what the first strategy was about, which carried us from 2004 to 2008. There was an implementation plan that guided regional organizations and their support to the various countries in the Pacific. There were 8 thematic areas which were in line with UNGAS, which by then we were all working towards. And these were split up into 4 components. The first, of course, is leadership and governance. The second was getting access to the increasing number of people living with HIV that were being diagnosed in the Pacific Island countries. So access to quality services. There was regional coordination of our efforts. We didn't want people doing the same thing in all the countries. So we wanted to make sure that there was a very clear division of labor amongst all the regional partners. And there was also program management. By this time, regional organizations were beginning to scale up their response to the growing national interest in HIV. And so organizations regional organizations were beginning to employ people, to have their own plans towards the HIV response to the Pacific, which were in line with the regional plan, and they supported national plans. Funding at the time was from Global Fund, the Australian Aid Program, the New Zealand Aid, and ADB, and of course French funding. And at this time, we began to do our own research in the Pacific instead of relying on global research. We were beginning to show that we were beginning to see higher numbers of HIV cases in various countries and a remarkable STI epidemic spread right across the Pacific. Consequently, our second regional strategy, which was then referred to as the Pacific Regional Strategy on STIs and HIV, we've got that in the wrong order, STIs became ahead of HIV to emphasize our response to STIs. It was telling us that we had practices in the Pacific that would put us at risk of HIV. And we had 6 thematic areas. The first one was prevention programs. And the evidence that came out of studies in the first strategy was indicating that our risk populations were seafarers and servicemen. And these were servicemen such as military and policemen who were doing duties, peacekeeping duties in other parts of the world and bringing home infections to the Pacific. So a lot of the prevention efforts were focused in these groups. However, in the strategies, we were relying on global evidence, and that said to us that MSM and sex workers and transgender were high-risk populations. And while they may have been on paper, if you look at actual activities on the ground in most Pacific Island countries and territories, there were very little activities in terms of prevention for these groups. And that also goes for drug users. The second thematic area was to scale up our HIV and STI diagnosis and testing. Up until this day, you can only get a HIV test mostly in the main centers in the countries, and that's an extreme limitation. It means that the entry point to the treatment cascade is limited because we can't test enough people out in distant areas from the major centers. The third thematic area was to concentrate on our continuum of care, treatment, and support systems. And I think this is where we may have picked and dropped programs from other settings. If you look at the Pacific response to the way treatment is established in the Pacific, it has been taken from Cambodia, a country which had a very successful rate in responding to HIV. But I sometimes question whether that is appropriate. But with a lack of evidence and a lack of experience in the Pacific, what else could we do but rely on what was done elsewhere? The fourth thematic area was leadership and enabling environment, and that was started in the first strategy, and that continued into the second strategy. By then, our leaders, religious and traditional and national leaders, were wanting to engage with community organizations, and that again was a success. They were seen as on a level playing field. Of course, strategic information and communication, we improved that. We tried to do a lot more of our own evidence. There were second-generation surveillance studies were done during this time. Studies amongst traditional high-risk populations such as MSM and sex workers were done during this time. And the last thematic area was governance and coordination. In this, we were talking about how we responded collectively to the HIV and STI epidemics in the Pacific. STI is a serious problem in the Pacific. 1 in 4 people under 25 will have chlamydia, and in one Pacific Island country, the rate is as high as 40% prevalence. And even in countries such as in Southeast Asia, among sex worker and MSM and transgender populations, you'll not see rates this high. So for us in the Pacific, STI was our major problem. And we rode on the back of HIV money to respond to STIs. And the response is from simple prevention programs to the extreme of mass treatment in many countries, where we were handing out treatment for chlamydia to just about everybody that qualified. Again, we improved our division of labor. We were all scrambling around, which was by then a lot of money. There was a lot of money pumped into the Pacific, and we were quite lucky. I sometimes wonder whether we used the money appropriately, but yes, there was quite a lot of money. We had Global Fund money from round 7. We had the Response Fund, which was a pool of funds put together by the Australian Aid Program and the New Zealand Aid Program. And also, by this time, countries were putting in money into their own response. Unfortunately, there's probably less than a handful of countries that have put in significant amount of monies for their own response. Most of the money is totally reliant on donor aid and has been driven mostly by regional organizations. In the second strategy, as you can see here, there was a lot of emphasis on engaging with, in a meaningful way, in community-based organizations. And that went through the planning of our policies, right through to treatment and care programs. We always engaged with the communities. And in this particular instance, it was mainly with people living with HIV. By this time, we hadn't really engaged with MSM, transgender sex worker populations too well. We were mostly engaged with people living with HIV. We've all had to learn so much. People living with HIV would have to sit in technical meetings, and many of them had no idea what we were talking about. And many of my colleagues who are doctors would ask on the side, why are they sitting here? Why are patients sitting with us at this meeting? So there was a lot of education that was going on about why they needed to be there. It was a response for them, and it was something that we needed to involve them with. And we're slowly getting policymakers on board in this particular way of approach. So as you can see on the slide, you can see some of the partners you may recognize, the common ones globally, UNAIDS, WHO, the various UN agencies. But there are specific Pacific-based organizations such as my organization, OSHAM. Also, the Secretariat of the Pacific Community, which is an intergovernmental organization that represents the 22 countries and territories of the Pacific. And so it's basically our own UN. So it was SPC and the Forum Secretariat which responded to HIV in the Pacific. They were the leaders of this response. So into the 4th decade. By 2013, our major funding was starting to dry up in the Pacific. The regional STI and HIV strategy had ended, and many countries were left with very little technical or regional support in terms of funding, and as well as technical support. Then we began the consultations for the next strategy. What would that look like? What steps would we take? We had to look back at the 2 regional strategies, and these are the things that we found out. We had better engagement with communities in planning and implementation of our strategies. Our programs were also visible nationally. There's greater evidence emerging over the previous 2 decades of the HIV situation in the Pacific, and it shows that it's less than 0.01% in most Pacific Island countries, so very, very low prevalence. And as I said, the STI rates are extremely, extremely high. So we don't quite understand why HIV hasn't exploded in the Pacific when clearly there are behaviors in the Pacific that allow for the spread of HIV. Our key populations, the evidence that's emerging in countries that are doing IBBS studies amongst MSM, sex workers, and also transgender populations is indicating that it's very much unlike our colleagues from PNG and also from Jamaica and Mauritius. It's mostly in the general population. It is not a concentrated epidemic in MSM and in transgender populations as well as sex workers. So that was quite interesting and something that's very different. Unfortunately, this is only for probably 2 countries we can say that for sure based on the evidence. Remember, there's 21 countries, so it could be different in the other countries. We still have, just like my colleagues, draconian colonial laws, which are English, and they still stand in many countries. But we've repealed many laws in some of the countries. Examples are in Fiji, the Constitution protects your right for gender orientation and sexuality. MSM activities are now no longer illegal, so you're accepted in Fiji. We have standalone legislation in many countries, such as Fiji, PNG, and Palau. Many countries are following suit by creating their own HIV standalone legislations. Some countries are developing their own HIV policies, and all the regional organizations have been part of this process, making sure all the boxes are ticked, all the groups are being involved in that process. Yet we still have prohibitive laws. We still stigmatize MSM and transgender populations, and also sex workers. There's still also a lot of drug use in the Pacific, and how the extent of the drug use in the Pacific is still hearsay in many countries. All the evidence is saying that there is drug use, but it seems to be a small number. So this is how it looks 3 decades on in terms of HIV prevalence. PNG is blue at the top, and you can see the Pacific, a very low prevalence in red at the bottom. So since 1984 to 2012, in the 21 countries, we've diagnosed under 1,800 patients. So for many clinics in some of the countries in PNG, that's the number of people they see. So it's a very low prevalence in the Pacific. So what lessons have we learned? We need to link HIV, STI, gender, and sexual and reproductive health programs. We need social research to inform our policies and programming. We need better evidence that shows the critical role of social, cultural, and religious factors that have on the effective implementation of our HIV, STI, and sexual and reproductive health programs for all sectors of the community. There's a need for a more country-focused and country-led strategic planning, and greater engagement with other key populations. As I've said, we've done a lot of work with people living with HIV, but very little work with other key groups. So what's the rationale for our change in approach? Number one, there's a need for a strategic document to guide Pacific Island countries and territories in responding to SRH issues as a whole. There's a need for a document that does not prescribe a one-size-fits-all approach, but one that has overarching guidance to sexual and reproductive health, which includes in there HIV. There's a need for a comprehensive approach which addresses the complexities of sexual and reproductive health. And there's a need for greater focus at most at-risk groups as well as vulnerable populations. So how did we modify this approach? What we did was we consulted widely, right across the Pacific. We included ministers and directors of health. We engaged with national and regional stakeholders. We included key populations such as MSM transgender, male and female sex workers, MSM and transgender sex workers, people living with HIV, people living with disabilities, youth, women, and many others. We were interested in how we could improve their sexual and reproductive health. And this is what we have come up with. For the next couple of years, from 2015 to 2019, we will be implementing the Pacific Sexual Health and Well-Being Shared Agenda. It's no longer going to be referred to as a strategy or a plan. It's called a shared agenda. Collectively, we will be implementing using 5 key areas. The first one is the use of our evidence and research, which means we need to be doing a lot more research and using it to guide our responses. 2, we need to integrate and link services. 3, we need to promote healthy behaviors. And the 4th is to create enabling environments. And 5, reach out to key populations. As you can see, we've tried to put this in a pictorial form. So what has been the change? For 2 decades, we moved from a disease-focused approach to one of the shared agenda, which hopes to improve access to comprehensive sexual and reproductive health for all, where we're saying that everyone matters, not only people living with HIV, but everyone else in the community. We need targeted approaches. Our challenge is now looking at how we can address the reduction in the resources available to the Pacific. And I leave with the following questions. What of the shared agenda? How will we implement it now with the lack of funding and resources to the Pacific? How do we carry this forward from here? Thank you.